Hello, dear students. I am Dr. Mushfig Orujov, Associate Professor of the Department of Pathological Anatomy of Azerbaijan Medical University. Now, I will present you our second lecture on pathological anatomy about the rheumatic diseases, the pathology of rheumatic diseases. The rheumatic diseases are following: the rheumatic fever, rheumatoid arthritis, systemic lupus erythematosus, systemic scleroderma, polyarthritis nodosa, dermatomyositis, rheumatoid spondyloarthritis, and Sjogren's syndrome. There are common factors of rheumatic diseases. First, the clinical course of these diseases is chronic. There are the chronic recurrent diseases that sometimes they activated, especially in the spring and autumn season. Then also they continue to the chronicity. The pathomorphology include the three features. All of these diseases present with the systemic damage of connective tissue. The former name of these diseases was the collagenosis or the systemic diseases. The character of pathologic process is immune inflammatory, and these all diseases are 4 stages in its development: the mucoid swelling, fibrinoid swelling, inflammatory cell reaction, and sclerosis. I hope you remember these some change some pathologic process from our pathological anatomy 1 course that we discussed about the extracellular or the mesenchymal proteinaceous degenerations and the features of the etiopathogenesis. First, the lack of clear etiological beginning. The immune factors act as a damaging agents here, or the immune complexes, antigens, antibodies, T lymphocytes, and all of them reflect the damage of humoral and cellular immunity. But there are differences between each diseases. They occur in nature, etiology, and localization of process. The primary etiological beginning, which act as a trigger. All rheumatic diseases divided into 2 groups. The first group is characterized by streptococcal infection, such as the rheumatic fever, systemic scleroderma, polyarthritis nodosa. But second group are triggered by viruses. For example, the rheumatoid arthritis, systemic lupus erythematosus, dermatomyositis, Sjogren's syndrome, and etc. Features of the localization of the pathological process. Despite the fact that all the rheumatic diseases are systemic connective tissue diseases, each of which is characteristic of a particular location where the damage is manifested with particular force. Here you see the rheumatic fever mainly affect the heart, rheumatoid arthritis joints, the systemic lupus erythematosus kidneys and skin, the scleroderma affect the skin, the polyarthritis nodosa affected the arteries, the dermatomyositis mainly they affect the skeletal muscles, bacterial diseases, vertebral joints, and Sjogren's syndromes, the exocrine glands. Here I will show you some figures regarding each of the diseases. Here you see the rheumatic heart disease at autopsy, which characteristic findings that include the thickened the mitral valves, thickened the chorda tendineae, here you see, and hypertrophic left ventricular myocardium. Here you see the rheumatoid change in the hand during the rheumatoid arthritis. Later we'll discuss about this change. Then the butterfly rash, the lupus facial rash. You see in the lupus here the gross view, the sclerodermic finger, and the polyarthritis nodosa. You see the affected arteries here. Dermatomyositis, the bacterial diseases, and the Sjogren's syndrome of the oral cavity. Each of these figures illustrated the of the rheumatic diseases. Now let me discuss about the rheumatic fever, or as we call it, rheumatism. The main reason of the rheumatism is a beta hemolytic streptococcus group A that obtained this disease is the rheumatic fever described by the Sokolsky and Boileau. So also this disease called as the Sokolsky-Boileau disease. Then the great contribution to the study of clinics and pathomorphology have the Aschoff, Talalaev, Skvortsov, and other scientists. The term rheumatism in the current sense has been in use since the late 17th century, as it was believed that chronic joint pain was caused by excessive flow of rheum or body-like fluids into a joint. So this disease called rheumatism or the rheumatic fever. There are four stages of the rheumatic fever. As we said, that mucoid swelling is first stage that duration approximately 15 days. Second, the fibrinoid swelling stage from 15 days to the 1.5 months. Third stage, the stage of the granulomatosis or the cell inflammatory cell reaction from 1.5 to 3 months, and the final stage of sclerosis from 3 to 6 months. Here you see the figure that illustrates the both of stages. Here you see the mucoid swelling, then fibrinoid change, the granulomatosis inflammation, and the sclerosis. As I said, we discussed about the mucoid swelling that during the some damages, alterations, the permeability of the blood vessels that increases here. The damaging effect role plays the immune complexes that they activate the prolytic enzymes, and the pH shift to the acid side in the connective tissue, and this results the accumulation of the acid mucopolysaccharides and the action of the acute mucopolysaccharides that increase the vascular permeability. When the vascular permeability increases, the plasma leakage from the blood into the connective tissue, into the extracellular matrix, and they affect the collagen fibers, and they became also the ground substance elements. They become the swollen, but not damaged here. And this damaged area here accumulated the mucopolysaccharides, proteins, the inflammatory cells, but this is irreversible, a superficial process of the connective tissue. Upon the termination of the damaging factor, there's a full recovery. But if they will not terminate it, the mucoid swelling stage will pass to the second stage of fibrinoid swelling, that characterized by a deep and irreversible disorganization of connective tissue. The pathomorphology of the fibrinoid swelling include following change: the complete destruction of interstitial substance and collagen fibers, picrinophilia, accumulation of natural polysaccharides, argentophilia. This argentophilia, picrinophilia, this ability of the staining with some stains, as the picrin, as the argentum salts, the increasing of the vascular permeability, vasculitis, that inflammation of the blood vessels, impregnation by immunoglobulins and fibrin. And the focus of pathology, or the focus of the damaged area, here is converted into a structureless mass of detritus with the advent of fibrinoid masses. The disease is based on three processes: the plasmorrhagia with the release of fibrinogen, disintegration of collagen and reticular fibers, and stromal protein denaturation. As a result, develops the fibrinoid necrosis, which is replaced by a raw area of scar tissue. Next stage is granulomatous inflammation, or the inflammatory cell reaction. At this stage, the damaged area forms the granulomas, these ovoid structures. You remember from the inflammation topic. And structure include the central necrosis, that in the periphery. Here we see we do the accumulation of the cells. Which cells? Here we see the plasma cells, we see the lymphocytes, as well as the very characteristic cells, the Aschoff cells and the Aschoff cells. Aschoff cells, also called the caterpillar cells. They have the ovoid nucleus and the chromatin that it's condensed toward the center of the nucleus in a wavy rod-like pattern that to some resemble a caterpillar. Larger Aschoff cells may coalesce to form the multinucleated Aschoff giant cells. Here you see very clear illustration of the Aschoff cells. Here, under the high power, we see the caterpillar nuclei of the Aschoff cells. Here also the visible, and the Aschoff cells is the multinucleated, the accumulation of the Aschoff cells, the large cells. So these granulomas is called the Aschoff Talalaev granulomas, or in some literature you will find the Aschoff bodies. There are three types of the Aschoff bodies, or the Aschoff Talalaev granulomas, or they also the stage of the development of these granulomas. First, the blooming or mature granuloma. This is the early stage, when just beginning the process of purification of fibrinoid necrosis. Then, discerning granuloma reflects the purification completion of pathological focus of necrotic masses. And finally, the scarring granuloma, the scars indicates the beginning of a recovery, where they must be localized. The rheumatic granulomas in many sides of our body. Especially you see the parts of the heart, the myocardium, the cardiac valves, the non-valvular endocardium, epicardium, the blood vessels, the tonsils, joints, the skeletal muscles, and most often the left atrial appendage. And the final stage of the rheumatic fever is sclerosis, because you know the final stage of the inflammation also the repairing process, and it begins the formation of the begins and the end of this process. And sclerosis present the formation of the abnormal scar tissue, or the fibrous tissue. There are four clinical morphological types of the rheumatic fever: cardiovascular type, polyarthritic type, nodular or nodose type, and cerebral type. Now I would like to inform you about the conditions of the tonsils in the rheumatism, as well as the palatine tonsils. As you know, the streptococcus infection of tonsils with the development of chronic tonsillitis is the first passing to the initiation of rheumatic fever. The streptococcus in tonsils cause sensitization and the formation of immune complexes, which include the streptococcal antigen. The streptococcal antigen, their properties close to the antigens of heart, so the immune complexes selectively affected the heart in the rheumatic fever. This is very popular phrase that the rheumatism kisses the tonsils, licks the joints, and bites the heart. And here you see the rheumatic change of the tonsils. Now we'll discuss about the cardiovascular rheumatism, or the cardiac type of the rheumatism. If they damage the inner layer of the heart in the cardium, we'll call the rheumatic endocarditis, or myocardium rheumatic myocarditis. If the process will affect the pericardium, we'll call the pericarditis. Also, the rheumatic pericarditis, rheumatic carditis, that in the cardium together with the myocardium will damage. If all three layers of the heart, all three tunics of the heart will covered by the pathological process rheumatic fever, we'll call the pancarditis. Rheumatic endocarditis. There are three types of these diseases according to localization. First, the valvular endocarditis, then parietal endocarditis, and chordal endocarditis. The rheumatic valvular endocarditis is localized in the depth of the valve, as well as in the left atrioventricular valve, the 75% or semilunar aortal valve. There are four types of the rheumatic valvular endocarditis as well. First, the valvulitis or diffuse endocarditis, acute water endocarditis, fibroblastic endocarditis, and recurrent vorte endocarditis. The diffuse endocarditis, characteristic for the diffuse mucoid swelling and edema of the connective tissue. This is the superficial and reversible process. The endothelium is normal, not affected, and occurs in the first rheumatic attack. Second type of the rheumatic endocarditis is acute vorte endocarditis. Involves not only the thickness of the valves, but causes the erosion of the atrial valve surface. The foci of erosion deposits 1 to 3 mm size blood clots, which have the appearance of small warts. So we call this vorte endocarditis. This is not true warts here. This is we call to show the blood clots, the thrombi. It may be results to thromboembolism, because this thrombi can separate from here and block some blood vessels, as well as the myocardium. These slides illustrate the pathological pathomorphology of the valves of the heart during the acute vorte endocarditis. This is the mitral valves of the heart. Here we see the formation of the thrombi that resemble the warts. There are also the short valvular endocarditis, or another name these structures vegetations. You can call also the vegetations. Fibroblastic, or you can call the fibroblastic endocarditis, shows the chronicity of the process that develops after repeated attacks of rheumatic fever, characterized by the thickening of the valve due to fibrosis. And final stage of rheumatic endocarditis is recurrent vorte endocarditis, that develops after next activation periods of rheumatic fever. On the valves disfigured by fibrosis in the foci of erosions are formed the thrombi that resemble the wart appearance. What differences between the recurrent wart endocarditis and the acute wart endocarditis? During the recurrent wart endocarditis, we must find the fibrosis in the valves. So if this process will continue, the rheumatic attacks will repeat it, the cardiac valves they shrink and fuse together. And heart defects are developed, especially mitral stenosis or the mitral failure of the mitral valves. In rheumatic fever, is always affected the mitral valve. It can be combined mitral and aortic valves. Less commonly, the process involves the tricuspid valve and the pulmonary valve. The heart defects can lead to chronic heart failure in patients, primarily the compensatory and then the compensatory phases. In most cases, this is the cause of death due to rheumatic disease. You see the gross view of the recurrent wart endocarditis. You pay attention to the fibrosis of the mitral valve and thickened the chorda tendineae also shown here. Rheumatic myocardium most commonly seen in rheumatic patients. It often develops with endocarditis in the form of rheumatic carditis. And there are three types of the rheumatic myocarditis: focal proliferative or granulomatous myocarditis, focal exudative interstitial myocarditis, and diffuse exudative interstitial myocarditis. Focal proliferative myocarditis or granulomatous myocarditis. At this time, the disorganization of the connective tissue occurs in the perivascular spaces of the myocardium. So here present the Aschoff Talalaev granulomas or the Aschoff bodies. In addition to granulomatous inflammation, parenchymatous perineural and fatty degenerations and even necrobiotic change can be found to some extent in cardiac muscle cells. The granulomas mark diffusely in all areas of the myocardium. Therefore, diffuse small focal cardiosclerosis develops in the myocardium during recovery. Here you see the Aschoff Talalaev's granulomas in the myocardial stroma. You see here the cardiac muscle cells, the nucleus, the striation here, some areas of blood vessels, but here you see the marked region that present the Aschoff bodies, and we discussed about the Aschoff cells, the caterpillar-like cells, and here you see the high power of the Aschoff bodies. Focal exudative interstitial myocarditis. In the myocardium, the focal exudative vascular reaction develops. The small and medium caliber veins are hyperemic. Edema, the weak stromal infiltration with neutrophilic and eosinophilic leukocytes, lymphocytes, and histiocytes are observed here. The parenchymatous perineural and fatty degenerations develops in cardiac muscle cells. But instead, the previous disease, the rheumatic granulomas are absent here, or maybe rare. These changes are considered non-specific morphological changes for rheumatism. As a result, small focal cardiosclerosis develops in these areas. And focal exudative interstitial myocarditis is accompanied by a latent course or weak activity of rheumatic fever in the clinic. And third type is diffuse exudative interstitial myocarditis. In contrast to focal exudative myocarditis, the alterative change and exudative vascular reactions are diffusely here and acute. As you see in the histologic slides, the edema, the lympholeukocytic and lymphohistocytic infiltration we can find in the perivascular spaces. Here you see the section of the blood vessels and the lympholeukocytic infiltration and acute hyperemia. In most cardiac muscle cells develops the degeneration and the necrobiotic change. even center of micronecrosis. So the consistency of the heart muscle is softened, dilatation occurs, the left ventricular chamber is emptied and expanded, and the heart grows in volume. Diffuse exudative interstitial myocarditis, which is common in most children, results in short-term decompensatory heart failure and usually results in death. Upon recovery, it proceeds to diffuse small focal cardiosclerosis. Rheumatic granulomas are rarely found in the myocardium. And let's summarize the rheumatic myocarditis. It may be healing or the recovery, the formation of the large and small focal cardiosclerosis, resulting with the heart failure and, unfortunately, with death. Now let me discuss about the rheumatic pericarditis, which is the inflammation of the pericardium, the outer cirrhosis of the heart in rheumatic fever. There are three types of rheumatic pericarditis: serous exudative pericarditis, serous fibrinous pericarditis, and fibrinous pericarditis that formation the core villosum. In all these types, the focal or diffuse sclerotic adhesion or even complete sclerotic obstruction may develop between the epicardium and the parietal pericardium. We call the restrictive and constrictive pericarditis. From this figure, you see the adhesion between the epicardium and or the visceral and parietal layers of the pericardium. The later the stone heart, the concretia cordis will develop due to the sedimentation of the calcium salt. And here you see the hairy heart. This is the fibrinous pericarditis. The fibrin accumulation you see on the pericardium, and the calcification or the stone heart we call the concretia cordis. Cardiovascular rheumatism. This pathological change in the heart, in the blood vessels, they are characteristic for the rheumatic diseases. The classic course of rheumatism, they characteristic change and have not been seen so sharply lately. This is called the pathomorphoso rheumatism. Thus, the acute course, complications, and deaths from rheumatic heart disease are prevented with the help of treatment and preventive measures using modern antibiotic and hormonal drugs. However, in this regard, the number of latent and prolonged chronic forms of rheumatism has become more common in children in recent years. All this contributes to the formation of heart defects in sick children at an earlier age. We have some discussions, some slides regarding the rheumatic vasculitis. The fibrinous swelling and fibrinoid necrosis occur in the walls of arterial vessels, and thrombosis occur due to severe damage to the endothelial layer. The vascular permeability in capillaries increases and develops the panvasculitis. The adventitial cells proliferate and forms a ring-like structures. Proliferation, severe degenerative and necrotic change, desquamation occurred of endothelial cells that we call the rheumatic endoteliosis. When the rheumatic vasculitis is stable, a sclerotic change occurs in the wall of these vessels. The rheumatic vasculitis can affect the person from any ethnic background, either gender, and from any age group. However, more often than not, the typical patient has long-standing rheumatoid arthritis with severe joint deformities from the underlying arthritis. Although the arthritis has usually led to significant joint damage, at the onset of the rheumatic vasculitis, the joint disease is paradoxically quiet. Here you see the patient's hand with joint damage from rheumatoid arthritis. The bulbous swelling of some knuckles and lateral ulnar deviation of the fingers you see here. The classic symptoms of rheumatic vasculitis. Rheumatic vasculitis has many potential signs and symptoms. The manifestations of this disease can involve many of the body's different organ systems, including but not limited to the skin, peripheral nervous system, arteries of the finger and toes, causing digital ischemia and eyes with scleritis. Scleritis, there's inflammation of the sclera, commonly occurs in the setting of rheumatic vasculitis. This ocular complication requires urgent treatment with immunosuppressive medications. In addition, generalized symptoms such as fever and weight loss are common. As is true with other forms of vasculitis that involve the skin, the cutaneous lesions can erupt on various areas of the body in rheumatic vasculitis with a predilection for the lower extremities. Typical findings include the ulcers concentrated near the ankle. Here you see the cutaneous ulcer, the open skin sore caused by an obstruction of the small blood vessels in the superficial ulcers or obstruction of medium vessels in a deeper ulcer. Most laboratory findings in rheumatoid vasculitis, for example, elevation in the erythrocyte sedimentation rate or the CRP, C-reactive protein, are non-specific and reflect the presence of a generalized inflammatory state. Hypocomplementemia, anti-nuclear antibodies, NA, and atypical anti-neutrophil cytoplasmic antibodies, as we call the ANCA, are common. The rheumatoid factor levels are usually extremely elevated. However, there is no definitive laboratory test for rheumatic vasculitis short of a tissue biopsy. The diagnosis must usually be made using a combination of history, physical examination, pertinent laboratory investigations, specialized testing, and sometimes a tissue biopsy. The differential diagnosis of rheumatoid vasculitis include the cholesterol embolization syndrome, in which a piece of cholesterol breaks off a plaque, may cause digital ischemia, and host the other symptoms that mimic vasculitis. Another disease is diabetes mellitus, cause of mononeuritis multiplex, but the multiple mononeuropathies occur over a short period of time are unusual in diabetes. The many clinical features of rheumatoid vasculitis mimic those of polyarthritis nodosa, cryoglobulinemia, and other forms of necrotizing vasculitis. Here you see the tissue biopsy slide. Normally, the cells of the blood vessels wall would be fewer in number and the lumen would be larger. But here we see the inflamed blood vessels. Here we see the accumulation of the inflammatory cells, and globular pink area, here is muscle fibers. You see muscle fibers. And here also we can find the inflammation around the blood vessels. So we call the vasculitis. Next form of rheumatic fever is polyarthritic form. As clear from the name, during this form, the many joints affected. Occurs 10 to 15% of cases in both children and adults. Develops the inflammation of joints, arthritis. In the other organs and tissues, almost no any significant change occurs. Only slight change are noted in the heart and blood vessels. Degenerative and inflammatory process in the small and large joints, especially in the knee joints, are observed in almost all rheumatic patients. So, serose or serose fibrinoid exudate is accumulated in the synovial cavity. The cartilage is normal here, and deformation do not occur in the joint. Symptoms of the polyarthritic form of rheumatism: the volatile joint pain, that starts in the knee, elbow, hip, and other big joints. All classic signs of inflammation are developed here, and muscular weakness and pain present here, possible here. Here you see the affected the knee joint during the rheumatic fever. Next form is nodular form, or the nodose form of rheumatic fever. Usually occurs in children, and the nodules from a few millimeters up to 1 centimeter are formed in the connective tissue, large aponeurosis around the joints and along the tendons. The nodules are painless and have a solid consistency. Here you see the formation of the nodules, subcutaneous nodules during the rheumatic fever, and erythemas, the round, the oblong shaped rash that develops in the skin. Cerebral form of rheumatic fever, also we can call the chorea minor or the Sydenham chorea. The name of the chorea taken from the Saint Vitus dance, that it demonstrates the obligatory position of the patients, that similar to the dancing of the Saint Vitus dance. So during this form, we can find the vasculitis in the cerebral blood vessels. The neurons, they undergo the degeneration as a necrobiosis, and the small diapedesic and hypoxic secondary destruction foci we can find on the brain tissue. Now we continue our lecture with next our diseases of systemic lupus erythematosus, or shortly you can call it as the lupus. This is autoimmune diseases second group. So most cases occur in women of childbearing years, starting from 18 to 25 years, develops by action of hereditary genetic factors. As the etiological factor, the role of viruses is more. The morphological change develops in 5 periods during the lupus erythematosus. First period is the degenerative and necrotic change, that all the organs and tissues, the connective tissue elements, undergo the degenerations and fibrinoid necrosis. Second period, subacute inflammation, vasculitis and polyserositis develops. The vasculitis in all of vessels of organ and tissues, and interstitial proliferative inflammation, and the inflammation of the serous layers, as the pericardium, the peritoneum, pleura damage here. Third period is sclerotic change, the diffuse sclerosing of stroma. For example, the peripheral tuberous sclerosis of spleen. Then immune competent systemic change, and 5 nuclear pathologies, or the nuclear change. In this stage forms the autoantibodies against the DNA, that we call it antinuclear antibodies, or the ANA or ENA. Pathogenesis of lupus erythematosus. The large amount of anti-nuclear antibodies are found in blood plasma. These immunoglobulins are called the lupus factor. DNA losing nuclei are pale stained with hematoxylin and eosin staining, that with the hematoxylin as called as hematoxylin bodies. And next term is lupus cells, or the LE cells. These are the macrophages that engulf the hematoxylin bodies. And lupus cells can be found in blood, the vascular wall, lymph nodes, bone marrow, and other lymphoid tissues. Here you see the smear taken from the blood smear, and the arrows show the lupus erythematosus cells, or the LE cells, are the macrophages that engulf the hematoxylin bodies. And this slide illustrates some clinical symptoms, some features: the butterfly rash in the face, and the skin damage during the lupus. And during the systemic lupus erythematosus, many organs they damage, as well as the skin that we found the butterfly rash and the red patch, the mouth and the nose ulcer develops, in the pulmonary system develops the pleuritis, pneumonitis, pulmonary emboli, pulmonary hemorrhage. The cardiac change include the endocarditis, atherosclerosis. When the patient has the severe abdominal pain, and from the blood side, the anemia, high blood pressure in the kidney. And later we'll discuss about the lupus nephritis. Then muscle and joints also affected, that we can find the pain and the arteries, sacs, the swollen joints, hair loss, high fever, abnormal headache. This is the clinical symptoms of the lupus. The non-bacterial thrombotic endocarditis, or the Libman-Sacks endocarditis, is the most characteristic cardiac manifestation of the systemic lupus erythematosus. Here you see the non-bacterial, and you can compare with the bacterial endocarditis that we discussed with you in the rheumatic fever. And here the histologic slide of the non-bacterial thrombotic endocarditis. WHO classification of lupus nephritis. As we said, that kidneys most affected organs during the lupus erythematosus, together with the skin and the heart. There are 6 classes of the lupus nephritis. First class, known as the minimal mesangial glomerulonephritis. The histological normal on light microscopy, but with mesangial deposits on electron microscopy. Second class is mesangial proliferative lupus nephritis. Typically responds completely to treatment with corticosteroids. Class third, the focal proliferative nephritis. Often successfully responds to treatment with high doses of corticosteroids. Fourth class, diffuse proliferative nephritis, mainly treated with corticosteroids and immune suppressant drugs. Fifth class is membranous nephritis, characterized by extreme edema and protein loss. And finally, the sixth class is glomerulosclerosis. As we said, the kidney affected during the lupus erythematosus, we call it lupus nephritis. And here we can find the hematoxylin bodies in the renal glomeruli. Fibrinoid necrosis very clearly seen here in this slide in the renal glomerulus. The formation of the hyaline thrombi is possible in these diseases, and we see with you the wire loop phenomenon. Why we call such? Because here the basement membrane thickened, basement membrane of capillaries thickened during the lupus nephritis. Next disease is rheumatoid arthritis. The etiology are the beta hemolytic streptococci group B viruses and mycoplasma. This is the autoimmune disease with the immunocomplex mechanism. The immunoglobulin G plays the role of autoantigen, and various fractions of the immunoglobulins play the role of autoantibody in immune complexes. These immune complexes we call as rheumatoid factor. They are synthesized in the lymph nodes and synovial membranes of the joints. The pathological change in rheumatoid arthritis. This occurs mainly in the small joints of the hands and feet, especially in the interphalangeal joints, and then in the large joints and internal organs. This organization and inflammatory process in the joints are divided into 2 parts according to their location. change in the periarticular connective tissue, change in the inside of the joint capsule or the articular capsule in synovial membranes and articular cartilage. The pathological change of periarticular connective tissue in rheumatoid arthritis occur in all stages of exacerbation of the disease, lasts approximately 4 to 5 weeks. Mucoid swelling, fibrinoid swelling, and fibrinoid necrosis in the connective tissue elements, vasculitis in the arteries and arterioles begin. The large number of or large amount of inflammatory cells accumulated around large foci of fibrinoid necrosis and rheumatoid granulomas forms here. Rheumatoid granulomas or the rheumatoid nodules occur mainly around large joints and in area of the body that are under pressure. In the elbow joint, the gluteal region, and sometimes even in the internal organs. The rheumatoid nodules usually occur in severe forms of rheumatoid arthritis. One of the characteristic change is the development of Baker's cyst, the large limited synovial fluid accumulation in the back of the knee joint. Here you see the illustration, the schematic illustration of the Baker's cyst and the figure taken from the patients. There are 3 periods of the synovitis in the rheumatoid arthritis. In the first period, the neutrophil-rich inflammatory cells and a large amount of exudate fluid containing rheumatoid factor accumulate in the joint cavity. Rheumatoid factor forms grape-like structures in the neutrophil cytoplasm that these neutrophils we call the rhagocytes. The synovial membrane became hyperemic, edematous. In synovial villi are fibrinoid swelling and necrosis that we call the rice bodies. In vessels develops the vasculitis. The cartilage is normal in this period. In the smear, the cytological slide, you see the rhagocytes. This is the neutrophils that filled with the rheumatoid factor that we call this rhagocytes. Here also you see here you see the normal synovium with the stroma and with the villi, the joint cavity, and you see the normal structure of the villi. But in the rheumatoid arthritis, we see the severe inflammation in the villi, the bluish color in the pathology, it showed that the inflammation, and the rice body, because the villi they separated, necrotized, desquamated, and they entered through the inside of the joint cavity. That we call the rice bodies. In the second period of the synovitis, the destruction of the articular cartilage develops and the villi they proliferated. It can last for many years even decades. Lympholeukocytic infiltration, the proliferative inflammation of blood vessels, develops inside the villi. Also, the proliferation of the synoviocytes is noted here, that is epithelial cells that cover the synovial membrane, and numerous granulation tissue forms along the ends of the epiphysis. The granulation tissue increases and extends to the synovial membrane, the villi and articular cartilage in the form of plaques, slices. We call this pannas. The pannas, the mass of the synovium and the synovial stroma, consist of the inflammatory cells. You see here the inflammatory infiltration that maybe include the T lymphocytes, macrophage, plasma cells, dendritic cells, and the fibroblasts, as well the endothelial cells. They cross over articular cartilage and cause this erosion. The pannas bridge the opposing bones, forming fibrous ankylosis, which ossifies, resulting in bony ankylosis, and inflammation in adjacent tendons, ligaments, and skeletal muscles is common here. Under the influence of the pannas, the villi destroyed. The joint cartilage is destroyed by necrosis. The part of the bone epiphysis inside the articular capsule remains exposed, and here develops the osteoporosis. The palms and soles become thinner, the fingers are separated and bent to the side, that we call this condition as the goose paw. The articular fissure narrows, movement is limited, and there are fragment dislocations. In the third period of the synovitis, they durate a long time, even the 15 to 30 years. In the joints forms the fibrosis, we discussed it, bony ankylosis, we call this seal of fins. In periarticular connective tissue develops the rheumatoid granulomas. Also, the internal organs also affected during the third period, the final period, the development of the polyserositis, the glomerulonephritis in the kidneys, the vasculitis in many organs, the secondary amyloidosis, and etc. Here you see the rheumatoid arthritis in the late stage or the late periods, the botonary deformity of the tongues, the ulnar deviation of metacarpophalangeal joint, the swan neck deformity of fingers. You see here the rheumatoid nodules, the high power of the boutonniere deformity and the swan neck deformity of fingers, the better shown here. And this slide illustrates the extra articular manifestation of the rheumatoid arthritis, that they affect the eye, pleura, pericardium, lymph nodes, kidney, lung, spleen, gut, muscles, skin, bone marrow, and nerve system. There are some clinical morphological types of the rheumatoid arthritis, as well the adult rheumatoid arthritis and juvenile chronic polyarthritis, that also has the three types, the monoarthritis, polyarthritis, and systemic visceral type. And there are the special types of the rheumatoid arthritis, such as the bacterial disease or the ankylosing spondyloarthritis, Feltis syndrome, Still's disease, Reuter syndrome, Whistler-Fanconi syndrome. And now let me discuss shortly about the progressive systemic sclerosis. It's one of the so-called connective tissue disease and affects many systems and organs. It is 3 times more common in women than in men and occurs mainly in middle age or older women. The main abnormality is an excess formation of fibrous tissue in tissues of organ. The fibrous tissue is particularly collagenous, leading to rigidity of the affected tissue, often with the destruction of specialized cells. Vessel wall thickness and perivascular fibrosis are characteristic features of systemic sclerosis and responsible for slowly progressive ischemic damage in a wide range of tissues. The skin is the most commonly affected organ in systemic sclerosis, but the alimentary tract, lung, kidney, and heart may also be involved. Skin involvement in systemic sclerosis is called scleroderma. In the skin, the systemic sclerosis causes hardening and scarring. The skin may appear tight, reddish, or scaly. Blood vessels may also be more visible. Where large areas are affected, the fat and muscle vestige may weaken limbs and affect appearance. Patient reports severe and recurrent itching of large skin areas. The severity of these symptoms varies greatly among patients, some having scleroderma of only a limited area of the skin, such as the fingers, and little involvement of the underlying tissue, while others have progressive skin involvement. The digital ulcers, open wounds on especially on finger tips, and less commonly the knuckles are not uncommon. And here we see with you the thick skin of forearms, the proximal scleroderma, and facial change, the pinched nose, the pursed lips, the canted eyelids, lip thinning and retraction, and immobile faces. So we completed our lecture. Thank you very much for your attention.